And so without further ado, I am going to turn off my video and welcome Bill McDermott as our president-elect to introduce our Quality of Life Award recipient.
Thank you, Jordan, and good morning and welcome to the third day of the AOSW conference. Judging by the feedback I've gotten so far, the conference has been a big hit, and I want to thank everyone 1,000 times over, and you know who you are, who helped make this possible. We're going to start today with the awards ceremony for the Quality of Life lecture. Established and sponsored by the American Cancer Society, this prestigious award honors individuals whose contributions through education, direct service, publications, and presentations reflect a commitment to quality of life for all cancer survivors. Thank you to the American Cancer Society for your continued support of AOSW in this award. I am thrilled to announce that the 2020 American Cancer Society Quality of Life recipient is Christina Bach. I first met Christina Bach about 5 years ago on the AOSW board, and we bonded immediately over our love for dogs. Anyone who knows Christina at all knows what an animal lover she is, and she especially has a fondness for beagles. It's one of the most endearing things about her. To quote Christina, during the COVID crisis, they have been her quarantine. As I got to know Christina, I was struck by her innovative nature, her drive to do well by the organization, and over the years she has shown such a spirit of generosity in sharing her knowledge. She has been kind enough to travel to my cancer center twice in New York City to give talks to our social work department. And of course, both were very well received. As education director, Christina guided AOSW through their ASWB accreditation process, created and established AOSW's webinar program, which had gone over very well, as you all know, and brought the clinical practice intensives and CE presentations from the special interest groups to the in-person conferences. I just remember how the quality of conferences improved so greatly during her tenure, and these changes have endured and continued. With her team, Christina has published numerous scholarly articles in journals such as Cancer, the Journal of Cancer Survivorship, the Oncology Nursing Forum, and Reflections, Narratives of Professional Helping. She has helped plan 4 AOSW conferences and has presented at numerous more. She is always a great source of ethics credits. She also helped create the New Jersey, Pennsylvania, Delaware Tri-State One-Day Conference. Christina is a clinical oncology social worker, a bioethicist, and a social work educator. She is the psychosocial oncology content editor at oncolink.org. She also serves as an instructor and field liaison at the University of Pennsylvania School of Social Policy and Practice, and as a financial and insurance specialist for the Cancer Support Community Helpline. Christina has practiced in oncology for more than 20 years in inpatient and outpatient settings. She also works regularly with her 2 certified therapy dogs, Linus and Huck, and in cancer treatment settings, as well as in literacy programs at local libraries. She also recently welcomed new addition Eugene to the, quote, Bach Beagle Gang. Christina serves on the board of directors and is a therapy dog evaluator for Comfort Caring Canines Incorporated. Christina also has experience in veterinary social work and does consulting and teaching on the human-animal bond, pet loss, and animal-assisted interventions and therapy and animal ethics welfare. You know, I direct this especially to the newer social workers in our organization. Over the years, I've had a number of people in AOSW who have been my role models. Christina has been one, and I just want to say, for those of you new to the profession, please reach out, to the others in this organization. There are so many who are willing to help you, guide you, and be friends with you too. So with that, I would like to introduce Christina Bach as the award winner today. Thank you, Christina, and congratulations.
Thank you, Bill. I'm crying now. I might need a moment.
I was going to say, would you like to take a 3-minute breather?
Yeah.
All right. Well, in the meantime, I can continue to say wonderful things about you. I also would like to thank Christina for all of her help that she has done, especially in our education development within AOSW. I've been with AOSW for 5 years myself. Oh, I'm not on video, sorry. I've been with AOSW for 5 years myself, and my entire first year with Christina, I started right after the Seattle conference. And so my first year was basically Christina showing me how to run a conference, and she helped me plan the Tampa conference. And since then, I feel like our personal and professional relationship has just grown so much. She is such a great, willing mentor, and she really truly thrives off of teaching others and helping them learn and grow and fulfill their potential. And for that, I am incredibly grateful myself. So I just wanted to thank Christina for that. And AOSW as an organization overall has been very lucky to have you as one of their members. And I appreciate everything you have done for us.
Wonderful. So I was going to say 10 minutes, I might get through 3 sides. So, so I just want to start by saying, wow, what a great moment to be here. Some of you may know that I'm a Hamilton addict, and I'm thinking in this moment of how stressful the last 5 months or so have been since the beginning of the pandemic. And then trying to put it in the framework of Hamilton going, look around how lucky we are to be alive right now. And that has such incredible meaning. And I'm hopeful that this talk might challenge us to think a little bit differently about the stress and the distress associated with the pandemic and how it's affected us, and how we might be able to think about being lucky to be alive in this moment, because maybe we can really influence some meaningful change. Right. I just want to take a second to thank a few people. First of all, to my dear friend and colleague, Bill McDermott, for that beautiful introduction. It's hard to believe that's me. And I am so blessed to have met you on the board, and I have loved my trips to New York with you and coming to NYU and talking with your staff. It's been so incredibly meaningful to me professionally and personally. I also want to thank the American Cancer Society, AOSW, the amazing conference committee, and the board of directors, and especially Jordan, Hannah, Christine, Andrea Ward, and Emily Birch, who have put on this amazing virtual conference in a really short period of time. And I am so glad to have been able to connect virtually with all of you. This has been a really important piece of my coping with my own isolation. And I'm so glad to be here virtually with all of you. I also just want to thank my incredible mentors. And if you don't have a mentor, I highly recommend it. But I want to thank Iris Feinberg, Penny Damascus, Shirley Otis Green, and Susan Garbino, who've been so incredibly giving of their expertise and their time and their support. When I first went on the board, I really had no idea what I was doing, and Iris would call me probably once a week and just check in with me, and so began a wonderful, amazing partnership and friendship. Susan Garbino taught me in the Smith End of Life Care program, oh my gosh, 17 years ago now. and taught me so much. And I'm so glad we were able to reconnect over the years. Penny Damascus is just, what do you say about Penny that hasn't already been said? She's an amazing person to connect with and to have in your dugout when you're going up to bat and needing help. And finally, Shirley Otis Green, who took me under her wing as part of the Excel in Social Work program, and has been just an amazing rock to me, and I'm so appreciative of all of you. I also want to thank my Penn Med social work family, a couple of whom are on this session with us today. In particular, my first ever supervisor, the person who hired me for my job, Patty Meehan, who's the director of social work at Penn Medicine. My colleague, Heather Klusaritz, who will kill me when I say yet again that she started as my student 19 years ago and has now grown into an amazing PhD who is influencing practice on the front lines of the COVID-19 pandemic in Philadelphia and has received federal grant funding to address some of these issues that are going on in long-term care facilities. I am proud of her beyond words and so happy and lucky she's still in my life. And finally, my ride or die from social work school, Carolyn Christofalo. We met like the first year of social work school in 1994. Oh my gosh, I really just aged myself. And we've been besties ever since. And I love you. Thank you for talking me down last night when I was having a complete meltdown about this talk. I appreciate you more than you will ever know. I'm also really grateful to having amazing folks that I work with on the Oncolink team, www.oncolink.org. Go and get all of the best patient education information you could find about cancer. My team is incredible. I also want to thank, fairly new, the CSC team that I work with on the helpline. Really just incredibly proud to be able to do clinical work in this moment with CSC. I also want to thank my crazy supportive little family, especially my fur kids who you've all just met digitally. I miss so much doing therapy dog work with them, which has really come to a halt because of COVID. And I'm really glad that they are my therapy source. And finally, I just want to thank all of my patients who I've been so lucky to work with over the course of the years. You inspire me every day. Whew, I feel like I'm a beauty queen, even though I'm giving that like thank you speech. It feels weird. Okay, so just a brief rundown of what we're going to talk today about today. These are the learning objectives, and I will tell you that when Bill called me and asked me to give this talk, I was completely flabbergasted, but also like, what do you want to talk about, he says. And I was like, I have no idea. And I really appreciated the ability to pick a lot of what I was going to talk about. And this talk has really morphed actually quite a bit since I wrote these learning objectives. So I hope you're willing to kind of take this path with me of where this talk ended up. Before we truly dive in, I just want to take a moment to recognize the difficulty of some of the content of this talk. I want you to know that I come to you today from a space of openness, vulnerability, and my incredible willingness to be wrong. As a social worker, I thought I'd been doing the work for the last 24 years by showing up, attending to social needs, identifying social risks, and empathically caring for others. But this work has been incredibly important and meaningful, and I know that I have made an impact. Over the last several months, I've learned that this has not been enough. I need to do more work, personally, professionally, and in my community to truly impact social justice, a pillar of our social work values in our code of ethics. This is a clinical and ethical imperative. I've got a lot to learn, and I'm hoping that you might want to take this journey with me, and this talk represents some of my first steps. So I'm going to go back in the Wayback Machine to February 25th, 2020. I was sitting in my office at Penn Medicine. I'm lucky, I've worked remotely for about 6 years, so this shift to remote work was not a shift for me. But once a week, our team would meet in person together at our office and have weekly meetings and just kind of go through some of the things that were going on with our work at Oncolink. And I got a text message notification on my phone that says CDC recommends that Americans need to start planning for a significant disruption to our lives. And I turned to my coworker, Carolyn, and I said, what the heck does this mean? And we kind of looked at each other and had no idea. And so now as I look back in that moment, I'm reminded of one of my favorite lyrics from the Grateful Dead song called What a Long Strange Trip It's Been. And the lyrics are, sometimes the light's all shining on me, and other times I can barely see. And lately it occurs to me what a long, strange trip it's been. And I think we need to prepare ourselves to hold on, because this trip is going to continue. 2 weeks later, this is what that meant. A significant disruption to our lives meant that schools were closed. Our work overnight became remote, or perhaps our work sites closed, or we were furloughed. And all of a sudden we were hearing terminology like, who's essential? What's an essential worker? Restaurants were closed, non-essential businesses were closed. In Philadelphia, when this first started, they closed the laundromats. And all I could think of was, if there's an essential business, it's a laundromat. Thankfully, they came to their senses and opened them a few days later. Daycares were closed. Many locations, especially here in the Northeast, where I live, were told that we needed to shelter in place. I, at that time, was in Massachusetts at my parents' house while my mom's recovering from surgery, and I ended up sheltering in place in Cape Cod for 8 weeks. That was not my plan. But as my parents and I always say, we all always have quarantine, and it was a special time that we had together that I'm really, really grateful for. And then finally, we had this introduction of the concept of social distancing. Now, I'm just wondering if anyone else had ever heard of the concept of social distancing before March. I certainly hadn't. I did not understand in any way, shape, or form that this meant not hugging, not going over to my neighbor's house or having my neighbor's kids come over to play with the dogs. No play dates, no coffee dates, which were so incredibly important to me. As somebody who's worked at home for so many years, one of the ways I was able to counter some of the isolation of that was that I would meet my friends for lunch or for coffee during the day. Nope, that's gone. And I think one of the things that also really stuck out for me was there were no funerals. And yet one of my dear close coworkers at Penn, her mom died right at the beginning of this pandemic. And all of a sudden, the look of the ability to memorialize her mom, to have that moment where family could come together, was completely changed. And there was no guidance, there was no support. If anything, we received a lot of mixed messages about what this whole social distancing thing was going to mean, as well as how long we're going to have to do it. And I think we know we're still doing it. So what's the result? Well, we've had this incredible experience of shared trauma and collective grief. When I talk about shared trauma, I mean that not only are we the helpers, but we may also need help. So while our cancer patients are coming to us in a cancer center to help them with their cancer, this is an instance where we also may be affected by the COVID-19 pandemic personally, in our families and our friends, that we too are struggling with going out to go grocery shopping, with being able to have access to the things that we need to have because of all of the shutdowns or changes to our life. So this experience was something we were sharing with our patients, and it impacted our work greatly. I've been struggling with this incredible inability and almost helplessness about being able to protect myself completely, and as well as my families, our friends, our coworkers, especially our clients. You know, my support group, I am so lucky to be involved with the Philadelphia Multiple Myeloma Networking Group as their social work facilitator. And they made an incredible shift to be able to meet online beginning in March. And we have had some of the most robust, meaningful sessions via Zoom with a lot of tech support and a lot of just pre-planning, but they're terrified. And I felt this incredible need to just, I couldn't connect with them in the same way over the Zoom room as I could when we were in our conference space together where we met. And I missed that greatly. So I was frustrated at times, I was angered. And the other day I came across this really interesting post about having COVID fatigue. There's a couple of funny memes that probably you've seen out there in social media, like being the person who always wears the masks feels like you're the person in the group project who always does all the work. That's how I feel right now. And in this quote I saw the other day, they talked about how those of us who are continuing to social distance, wearing masks, taking this really seriously, are holding a societal umbrella in a downpour. The others are laughing and pretending it's not raining because they're not wet, but we're soaked and it's exhausting. And so I'm feeling a lot of that in my personal life, but also professionally, just thinking about how to work with folks who might think differently than I do. And finally, and I think we could probably have an entire session just on loss and bereavement related to the pandemic. Again, this is very much a universal experience. We are all suffering losses every single day. And I think people don't like to say, I'm grieving. You know, grief has in many cases been a very private, personal space. And we're definitely seeing this in the pandemic. And I've been encouraging a lot of my clients that you need to really own this as a grief, as a loss, as something that you need to think about how that loss is going to affect your life, as well as how you're going to adjust after that loss. Perhaps for me, one of my biggest losses during the course of this pandemic, and please bear with me because you may laugh at this, but one of the first things that got canceled was one of the most meaningful events in my life, which is the Maryland Sheep and Wool Festival. Every May for the past 17 years, I have traveled to Maryland to go be with my knitting people, where we would just be with the sheep and the alpaca and the llamas and buy way, way, way too much yarn. And it got canceled in March, and I was devastated because this thing that was such an important part of my life was gone. What we did was we shifted, and we had this awesome online event with the vendors, and it was really also impactful because these vendors tend to make their entire income off of some of these festivals. So it was really great to come together as a knitting community. Yes, there is such a thing. To all my knitters in the room, you can find me on Ravelry. But that was a really important part of community for me. I also lost my dog Maggie during this quarantine, and that was also really devastating. She was 16 years old and a cancer survivor herself. And all I wanted after she died was to hug somebody. I needed a physical connection with someone. And I was so caught up in sadness and grief after losing her, even though it was not an unexpected loss, that about 5 days after, I went over to my friend Jane's house. And I was sobbing as soon as I saw her. And I said, I don't care, I need a hug. And she's like, I don't care, I'm giving you one. And it was really what I needed in that moment. And so recognizing the impact of those losses for me in that moment really helped me be able to continue coping with this quarantine we're living under. If you participated in the webinar that I had done in April, then this quote is not new to you. But if you didn't, I'm going to read it because I saw this in social media in April, and it has stuck with me for all of these months. That this pandemic has highlighted privilege. And I quote, social distancing is a privilege. It means you live in a house large enough to practice it. Hand washing is a privilege too. It means you have access to running water. Hand sanitizers are a privilege. It means you have money to buy them. Lockdowns are a privilege. It means you can afford to be at home. Most of the ways to ward off COVID-19 are accessible only to the affluent. In essence, a disease that was spread by the rich as they flew around the globe will now kill millions of the poor. All of us practicing social distancing must appreciate how privileged we are. And this was posted by a physician in India. This is an uncomfortable space with me. And I want to challenge you to be asking yourselves these questions in your own community, because perhaps some of this is coming up more now as we're seeing the epidemic grow to other areas of the country that at the beginning of this weren't necessarily as greatly impacted. But what communities or populations don't have the resources to practice social distancing? Where I have seen this in my own area in Philadelphia is with a very large homeless population who I am extremely concerned about and also feeling incredibly powerless in terms of making real change for the homeless population in this city. They actually have created an encampment down on the Parkway, which is where all the art museums and everything are, and are in negotiations with the city. This came up after some of the Black Lives Matter protests, but it's also been a really heated space. And I'll tell you, the one time I've been out to eat dinner since the pandemic began, which was about 3 weeks ago, I went and ate outside, and then I came home and probably scrubbed my body more than I need to because I was so terrified. A homeless man came up to us at the table, and I was deeply affected. And the first thing I said to him was, "Do you mind giving us a little space?" He said, "Absolutely not." And then I said, "Are you able to get yourself safe?" And he said, "No, I'm not." And I asked him, "Would you like me to call someone for you?" And he declined. He was like, "Nope, I'm better. I'm better off on my own." I gave him some money. I taught him how to put his mask on right. But in that space, I really felt like, damn it, I need to be able to do more. I also want to encourage you to be asking yourselves questions like, what does it feel like to think of the ability to practice social distancing as a privilege? And finally, what underlying inequities in our society has this pandemic exposed? Well, I can list them off for you on my hand. Jobs, education, access to healthcare, access to technology, and public safety. Great inequities in all of these areas. And then came May 25th. On May 25th, George Floyd was killed by police officers in Minneapolis. Before I dive into this, I'm just going to give another sort of trigger warning that this may be uncomfortable. Talking about this is uncomfortable, but we must address this in this moment that we are in. This was not the first, nor will it likely be the last time that we witness or experience the killing of a black or brown person at the hands of law enforcement. A little history lesson here, that the Black Lives Matter as a movement started 6 years ago after the killing of Michael Brown. And this is where this gets incredibly vulnerable for me. So please, I hope you will give me levity. I have to be honest with you. I used to be an all lives matter person. I'm a social worker. We advocate for everyone, the dignity and worth of all persons. But did you know when I finally got it? In 2018, I was jumping in my car to go to the Philly airport to protest the Muslim travel ban. And in that moment, I understood that it was their lives that needed help. And suddenly it hit me like a ton of bricks. And so I'm really trying to use my own personal experience when people say, well, all lives matter. Yes, of course they do. But in this moment, Black lives need our help. And what happened with the killing of George Floyd, coupled with the pandemic, and I want to thank you, Carrie Borden, for talking with me about this. If you guys don't know Eukarya, you should, but most of you do. We talked a lot about what happened with George Floyd, and she said something to me like, I don't know that it would have been the same without the pandemic. That coupled with the pandemic, it increased the traction, the visibility, and the activity of the Black Lives Movement and took it to the next level by highlighting this coexisting public health crisis that is systemic racism. In June, as protests erupted and revived energy in the Black Lives Movement was experienced around the world, it was obvious to me that we could no longer be on the sidelines of this movement. Silence was not an option. It was complicit in reinforcing systemic racism. And it was then that I was introduced to this notion of being anti-racist. And not only did I need to be anti-racist, but so does social work. Ibram Kendi describes anti-racist as one who is supporting an anti-racist policy through their actions or expressing anti-racist ideas. So it's important that we understand the inequity of race in the context of cancer and COVID as we start our journey to be anti-racist oncology social workers. I wanted to highlight for you some of the disparities that happen in cancer care. Likely many of you already know these, but we can't ignore them. That Black women are more likely to die from breast cancer than non-Hispanic white women. and that Black men are more likely to be diagnosed and to die from prostate cancer than non-Hispanic white men, and that Black men and women are more likely to be diagnosed with multiple myeloma and leukemia than non-Hispanic white men and women. But also that Black women have a 3.1% risk of dying of breast cancer compared to a 2.6% risk in non-Hispanic white women. They also have double the incidence rate of triple negative breast cancer compared with white American women. And we know that triple negative breast cancer can be more aggressive and harder to treat, and oftentimes is later diagnosed. We've seen that in most cancers, that cancer risk increases as socioeconomic status decreases. In 2017, 21% of Blacks compared to 9% of non-whites were living below the poverty level. And because of the historical context and social structure, race is strongly correlated with the socioeconomic status in the US. It's also important to think about clinical trials in the cancer space. Only 12 states allow Medicaid to cover the routine costs of clinical trial participation. This systematically excludes individuals who are socioeconomically disadvantaged from access to cutting-edge research therapies. Also, according to the AACR, Black and Hispanic patients with breast, lung, colorectal, and prostate cancer were 30% less likely than white patients to enroll in clinical trials testing and treatments for these 4 types of cancer. I thought for years that this had to do with the experience of people of color and their great mistreatment, mostly around Tuskegee, because that's what I've learned about. I'm reading a great book right now, which I want to recommend to all of you, called Medical Apartheid. And I'm learning that not only was Tuskegee a great abuse of Black men as a research study, but that even our constructs and our systems of how we publish data, how we access data, who has access to our data, who has access to reading articles that we write about the work that we're doing, is systemically racist. So a really interesting, fascinating book. I'm going to talk about a couple books in this talk, and I'd be certainly happy if folks are interested for us to think about having some sort of book group to discuss some of these books. This is a chart from the AACR, again, American Association of Cancer Research. This also highlights some of the disparities that are coming up in survivorship. And in particular, and I found this interesting because I talked to a woman last week on the helpline who is a breast cancer survivor who is having horrible lymphedema and just completely unable to get what she needs to help manage the symptoms associated with her lymphedema. But African American women have a 2-fold increase of breast cancer related lymphedema compared to white women. And they also have a higher risk if they have a HER2 positive breast, HER2 negative, HER2 targeted, that they have a much higher risk of cardiotoxicity compared to white women. Also, that cancer survivors who live in rural areas are 23% more likely to report psychological distress compared with those in our urban areas. So there's a shout out to all of our rural social workers on the line today, that we see you, and we hear you, and we know that folks in your areas might be have a more prevalent experience with cancer-related psychological distress after treatment. There's also incredible systemic racism and disparities in the COVID-19 pandemic. This data was published in the New York Times on the 5th of July, so a month ago now, and the data itself is dated back to May. I want to make sure that everyone understands that the impact of systemic racism was even felt in the ability to access this data. The New York Times writers who wrote this article had to sue the Centers for Disease Control and Prevention to get access to the racial data associated with the pandemic. What we're seeing as a result, though, in the data is a disproportionate infection rate across the country, regardless of whether you're in an urban, suburban, or rural area, and this disproportion is based in race. That Latinx communities have 73 cases per 10,000 people, Blacks 62 cases per 10,000, and whites 23 cases per 10,000. So 2 to 3 times greater case rate in Black and Latinx populations than in the white population. some further data from that study. Again, coronavirus cases by 10,000 per 10,000 people by age and race. Again, you see large discrepancies and disparities in terms of numbers of cases between whites, blacks, and Latinos. It gets even scarier though when we start talking about death rates. This is from the Brookings Institute, which highlights death rates due to COVID-19. Blacks are represented by the orange bar and the graph, whites the blue bar, and the Latinx community by the gray. And as we can see, death rates are much higher in the other, in both Black and Hispanic Latino communities. It gets worse. This actually is a really important slide because it really depicts the disproportionate rates of death. So whites make up just under 60% of the population in the United States, about 21% of the deaths related to COVID. Whereas Hispanic or Latinx make up just under 40% of our population, but represent over 25% of the deaths related to COVID. And that non-Hispanic Blacks make up about 14% of the population, but again, represent nearly 25% of the deaths due to COVID. What's also super concerning to me is the graph on the right. Non-Hispanic American Indian or Alaskan Native population make up a very small percentage of the overall population in the United States, and a disproportionately high rate of death due to COVID in the United States. I hope that this is making you upset and angry, because it makes me upset and angry. So we must address social determinants of health, because that is fueling all of these disparities. So let's talk about what social determinants of health are. Healthy People 2020 puts these into 5 categories: health and healthcare, social and community context, education, economic stability, and the neighborhood and built environment. I just want to highlight a couple of things that what those things mean, so you have a little better grasp of what a social determinant of health is. So when it comes to health and healthcare, we're talking about access to healthcare and access to primary care, as well as health literacy. The ability of the individual to understand their health issues, their medications, their ability to access care, the tests that they need, and what they need to do to prevent disease. In the social and community context, we're talking about things like civic participation, discrimination, incarceration, and social cohesion. In education, what are the opportunities for early childhood enrollment and education, and higher ed, and high school graduation, and language and literacy? For economic stability, what is the community looking like when it comes to employment, food insecurity, housing, or poverty? And finally, the neighborhood and built environment addresses things like access to good and healthy foods, crime and violence, environmental factors in the neighborhood, as well as quality of housing. All of these are impacted by the systemic racism that is felt. The WHO defines social determinants of health as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life, including economic policies and systems, development agendas, social norms, social policies, and political systems. They are not inherently positive or negative, and they give benefits to some but cause disparities for others. And those disparities are caused by systemic racism. Again, this is just the definition so you have it and understand that social determinants of health are structural policy level factors that create and augment risk for health problems at a community and population level. This is what we do every day, though. We address social needs and social risk factors. Social needs are patient-centered and driven, and they are what needs to be attended to most immediately for that patient. We also do things like distress screening. So we screen for social risk factors that help us understand a larger pattern of adverse social conditions associated with poor health. And there's also the possibility that patients are just There's a great book called Pedagogy of the Oppressed by Paulo Freire. I read it my freshman year in college, and one of the most important things that I read in that book was that the longer a population is oppressed, the more they start to believe it. And so what happens with social risk factors is that oftentimes patients have experienced these risk factors for so long that they're almost ingrained in their identity and they don't understand them, but they feel them. So that screening is super important for us to do. This is really at a much more granular level than the larger policy-driven work in the community and population level of social determinants of health. So what do we got to do, guys? We got to pivot. It's my new favorite word. And if you're a fan of the show Friends, I'm a sort of fan. I'm a Fairweather fan. There's a great episode where Ross, pictured here, is trying desperately to get this incredibly oversized couch up this staircase that winds around. He's drawn pictures and charts, how it's going to work, and it does not work. And he just keeps screaming, pivot, pivot, pivot. And I couldn't stop thinking about the pivot when it came to talking about all the things that we have been doing throughout the course of the pandemic. So what does it mean to pivot? I'm a big fan of definitions. And again, Ibram Kendi, the author of How to Be Anti-Racist, says that definitions anchor us in principles. And the pivot might be a new principle for us. The definition of pivot is a noun, a shaft or pin on which something turns, or as a verb, to turn on or as if on a pivot. Synonyms are revolve, rotate, spin, swing, swirl, turn, twirl, twist, wheel, whirl. That's not at all a tongue twister. And in this context, in the pandemic, in the moments with Black Lives Matter, it means that we as social workers need to change course, adapt, attempt new things, and answer this new call for action. We've certainly made clinical pivots. I'm hoping that you're all thinking about what it means to practice socially distanced oncology social work. I'm going to be honest with you, I need to pivot right now because there's a Beagle wrestling session going on right behind me. So if you hear me say, hey guys, stop it, that's why. Hey guys, they're here. I also hope that you're thinking about what does it mean to practice anti-racist oncology social work? What are some of these unique challenges that we're feeling in this moment where we're working with both of these issues? I've really struggled with our work being essential, but us not necessarily being considered essential personnel. It's a very difficult space for me to navigate. And I'm wondering about how we advocate for our work, our clients, and ourselves. I think we're still very much in an infancy stage right now in understanding some of these things related to our clinical practice related to the pandemic. Overnight, many of you became tele-oncology social workers, and I'm sure you weren't expecting that. So I'm hoping we can do some polls now to kind of understand what's happening in the OSW practice in the age of COVID-19. Thank you for putting up the poll. How did your workplace setting, sorry, that should say your, I did write these very late last night as I was stressing out. How did your workplace setting change as a result of the pandemic? Not at all. I was transitioned to telehealth services. I'm working a hybrid. I already did remote work before the pandemic, or I was laid off or furloughed. So let's take a minute or two for folks to answer. I'm going to take a drink of water. Wow. Thanks for that. So not at all. That's a really much higher number than I expected. That 27% of you have been working on site throughout the pandemic. I know someone who I work with in Philadelphia has been on site at her hospital through the whole time. And in my own hospital, most of the social workers were pulled at the beginning of the pandemic. Many of them have gone back. Nice to see that a lot of you have transitioned as well to tele-OSW services, and some are working a hybrid. And I knew that we definitely had folks who have suffered layoffs or been furloughed as a result of the pandemic as well. I'm going to give you guys a little special shout out and some love because, wow, this is rough because the cancer goes on despite the COVID. All right, Christine, can we go to the next poll question, please? which is when the pandemic began, did you have access to technology to provide tele-OSW services? Right. Not at all surprised that while it's, you know, fairly close, that 55% of you did not have access to technology. And I'm not sure that we still have the technology that we need to really be doing this work to the best of our abilities. Finally, Christina, can we do poll number 3, which is what has been the biggest challenge for you when it comes to working remotely? And there are several responses, so be sure to scroll down. So the vast majority says the biggest challenge is making that personal connection with patients and families. I agree. It's something we're talking about a lot at the School of Social Work level as we're transitioning for the most part to online teaching. How do we teach our students as well about making personal connections, which again goes back to our code of ethics and valuing personal relationships when we're doing it in a really different space. Also, really not surprised that some of you are feeling disconnected from your team, as well as really struggling with our clients' lack of access to internet technology. And it's not even like lack of access, but also just a lack of how to do it. I've spent a lot of time on my helpline shifts with just helping people with basic email access. A lot of people do not have printers. Like some of that has really definitely been a challenge when it's come to shifting to this work. Thank you all so much for participating in those chats. I really love these chats because I think it's been a really interesting space for us. Okay, in the interest of time, I'm going to go to the next slide, and I have one more poll for you, which is, and I think this chart shows you some of the social needs I've seen and heard about being exacerbated as a result of the pandemic. I'm wondering what has been the most challenging for all of you to manage with your patients during the pandemic. Great. Social support and isolation, 39%. Loss of job and income, 23%. Transportation. This one is actually surprising me. I've been hearing a lot on the helpline about people who need housing for treatment. And with so many of the go-tos that we rely on for resources to house patients during treatment, for example, Hope Lodge closing due to the pandemic, I was expecting to see that to be a little bit higher. It's interesting that you have the social support and isolation. Some of you may remember that back in April, my team did a survey with cancer patients related to COVID, and I can tell you we've closed the survey, and my awesome research partner, Isabella, who's on the call today with us as well, has done a great job mining data, and we've definitely found some significant correlations between social support and some other psychosocial issues going on for cancer patients. So stay tuned. We're hoping to publish some of those really soon, which I think validates right here what you guys are saying has been one of the biggest challenges. So now we also need to address, because this is technically an ethics section, ethical challenges and pivots. So I always remind people that we have core values that are in our code of ethics: service, social justice, the dignity and worth of a person, importance of human relationships, integrity, and competence. Think about these things as we're talking about things like transitioning to telework, as we're talking about resources are available, as we're thinking about how we connect with our clients in this new way through screens, through the phone lines. All of this has been infecting our ability to practice under these social work core values, and really, I think in a lot of ways, challenging us as a profession to think about what needs to change. I also feel like I have been walking on hot coals for the past 5 months when it comes to some of these hot zones. If you have not spent some time with the Code of Ethics since 2017, you should. At that time, it was updated to really include aspects of technology. And we really were the first profession to put a lot of things in about doing Google searches about clients, using social media, props to NASW for that. I think we're going to need to rethink a lot of it after the pandemic. One of the things that's been incredibly challenging is how do we obtain informed consent to work with our clients in an online space, especially if there are quote unquote forms that they need to sign, but they have no access to sign those. They don't know how to use a fillable PDF. How do we pivot to be sure that our clients are truly informed about the treatment that they're going to be receiving with us? Also, there's great concerns about privacy, and I'm not just talking about your client's privacy, but our own privacy. You guys are in my house with me right now. You heard the dogs bark in the background. This is a self-disclosure right here. And as social workers, we've talked for years about boundaries related to self-disclosure. Those have all sort of gone by the wayside because of where we are doing our work now. I also posed to you the question of what happens when you're doing a video call with a patient and in the background you see something that might be reportable, maybe to a child abuse hotline. What are our obligations of what we witness going on in the background when if we were just seeing our client face to face, we wouldn't have had any kind of access to? We also need to have concerns about confidentiality, how we respect our patients' confidentiality. I asked in one of the polls about having space to do sensitive work. I think at the beginning, a lot of us who never worked from home before were trying to figure out where that was going to happen when we were also homeschooling and our spouses were working from home and our dogs were barking in the background, and how did we really find the space to have true confidentiality and moments with our patients that we felt we could protect them. And finally, this is actually, you know, if you came to my talk in Atlanta, where I did a whole dismantling of the NASW Code of Ethics changes, this came up as really one of the biggest challenges, which our code says that we are to practice under the rules of the jurisdiction in which we are located and licensed in. And wow, it's a big problem right now because we are practicing in spaces, talking to people across state lines. Those are our clients. And maybe before the pandemic, I mean, I live in a space where people come from New Jersey and Delaware and Maryland to get treatment. My code of ethics says I'm supposed to probably not do that, but I need to provide them with care. So again, folks have had to pivot. I also want to really encourage you to think about how you're going to integrate digital humility into your own practice. Practice with your older parents. I do this all the time. Love you, Mom and Dad. So happy to show you how to use Zoom for the 9,000th time. We need to keep doing this with our patients as well. Whether we're asking them questions like, what device are you working on? Are you on a computer? Are you on a smartphone? Are you on a tablet? What browser are you operating in? I know some of these things because I work for a website full time, but it really does make a difference in helping us understand how our patients are accessing the tools that we are asking them to use to have access to us. Just really quickly, trying to remain on top with time, reviewing that as a result of the pandemic, there have been HIPAA suspensions, state-level changes impacting licensure and supervision, as well as CMS expansion and telehealth waivers. This again is included in part of my April webinar, but I want to make sure that everybody understands that a covered healthcare provider that wants to use audio or video communication technology to provide telehealth to patients during the pandemic can use any non-public facing remote communication product that is available to communicate with patients. I just want to say that again, any non-public facing remote communication product. There's been a lot of discussion on SWAN about HIPAA compliant social media usage or technologies or platforms. Right now, we can use whatever we want, regardless of whether they have HIPAA compliance. It is scary. It feels like the wild, wild west. We need to inform our clients, however, again, this goes back to informed consent, if we are using a platform that might not necessarily be under a HIPAA compliant type of contract, as well as making sure they understand the limitations of privacy. Under that notice regarding those HIPAA suspensions, it did call out tools that we are allowed to use for video chats, which include Apple FaceTime, Facebook Messenger, video chat, Google Hangouts video, Zoom, or Skype to provide telehealth without risk for penalty of non-compliance with HIPAA rules. So that's huge. They also called out things that we are not allowed to use, including Facebook Live, Twitch, and TikTok, or similar video communication applications which are public facing. They should not be used. CMS also made some temporary measures to make it easy for people who are enrolled in Medicare, Medicaid, or CHIP to receive medical care through telehealth, and for providers to be able to bill for those, and to help them practice remote care even across state lines. So there were some changes in that space as well. I also encourage you to check with your own state licensure board about changes that have been made in the state that you live in. For example, in Pennsylvania, before the pandemic, we were only allowed to get, I think, 10 of our 30 credits for licensure renewal online. Now we can get them all. We also were not allowed to do remote supervision, and now we are permitted to do remote supervision, which I actually think is a change that we should embrace and be doing ongoing. I think it's really important. So what do? I'm a little bit of a closet photographer on the side. One of my favorite things to do when I go to AOSW every year is I tend to travel before or after AOSW and play with photography. So I wanted to use this image to think about how we change our lens, adjust our focus, widen our aperture, and get back to social justice. This is core for what we need to be doing to really guide our practice at this point. And I'm going to read this again. This is direct from the Social Work Code of Ethics. Social workers pursue social change, particularly with and on behalf of vulnerable and oppressed individuals and groups of people. Social workers' social change efforts are focused primarily on issues of poverty, unemployment, discrimination, and other forms of social injustice. These activities seek to promote sensitivity to and a knowledge about oppression and cultural and ethnic diversity. Social workers strive to ensure access to needed information, services, and resources, equality of opportunity, and meaningful participation in decision-making for all people. It's right here in our code and gives us a great backbone for thinking about how we are going to become and develop the process of being anti-racist oncology social workers. We need to stop working in tunnels. Not sure if you all know what this is, but this is the Lincoln Tunnel. And there are 3 tubes. Sometimes 2 of the tubes are going into town. Sometimes 2 of the tubes are coming out of New York City. I found this to be interesting imagery when thinking about what's happening in terms of addressing those social determinants of health we talked about a little bit earlier. That medicine, public health, and social work are completely devoted to changing social determinants of health, but we are working in our own tubes of the same tunnel. And that in these tubes, the traffic may feel different, the flow may be different, there might be construction, there might only be 1 lane in one might be really, really congested, the other you might be able to fly through, but instead we really need to think about how we can bring our tunnels together and stop working in this tunnel type environment. So I also want you to think of that age-old thing we always talk about in social work, the onion, peeling the onion to get at the middle. What's in the middle of the onion? More onion. I want to challenge you to think about being cogs in a wheel, and that our cogs of things that we do at the person level impact what happens at the profession and the community level and the policy and advocacy level. And one cog cannot operate without influence from the others. This COGS model needs healthcare systems, public health, and social work to work together to make change at that policy and advocacy level. This is driven by the movement in the COGS at that person and professional level to address social needs and identify social risk factors that inform the larger work at the policy and advocacy level. A couple weeks ago, my former student and dear friend, Andrea Strauss, also here on the call today, shared this quote on Instagram, and I loved it. because I think this also needs to really be part of us carving our future as anti-racist oncology social workers. We will not go back to normal. Normal never was. Our pre-corona existence was not normal, other than we normalized greed, inequity, exhaustion, depletion, extraction, disconnection, confusion, rage, hoarding, hate, and lack. We should not long to return, my friends. We are being given this opportunity to stitch a new garment, one that fits all of humanity and nature. It's time for us, in the words of John Lewis, who I was absolutely devastated by his death, and watching his funeral and all of the amazing, amazing eulogies that were given in honor of him, especially President Obama, who I really needed in that moment. So in his words, it's time for us as oncology social workers to make good trouble in oncology and healthcare social workers, to work towards dismantling these systems of racism that have caused these healthcare disparities we talked about earlier, and to reconstruct this construct of normal or new normal. I really have always hated that, new normal. Again, at the beginning of the pandemic, Carrie Iris shared a really interesting article about this being a new now, which I've really embraced through the course of the pandemic. But I want us to think about defining what our lives are going to look like post-pandemic as oncology social workers. So I challenge you to get out your sewing needles and prepare to make your stitches in what our post-COVID garment is going to look like. What does that cancer care look like for you? What can you do, and how will you do it? I want to challenge all of you to start this fall with voting. And in particular, helping your patients and your team members, if they want to have access to a mail-in or absentee ballot, that you help them be able to do that. If they aren't registered to vote, help them. If they want to work at the polls, volunteer to be a poll worker. I'm also charging you to pledge to be anti-racist. Get involved in writing or rewriting the mission statement of your organization or your department that includes something about your organization being anti-racist. I did this for Oncolink, and it was an incredibly empowering experience for me to add that to our mission, which lives on our website. I also want to encourage you to take advantage of online events with Black authors, to ask questions, to have difficult, uncomfortable conversations, and to be sure that you are mentoring persons of color, LGBTQI students at an early space. Get them involved, get them thinking about how they can make a difference by being social workers and helping us to reframe our social justice frameworks after COVID. I thought I would ask you if you would be so kind to indulge me in a collective exercise for us to end. I'm hoping that in the chat box, you would be comfortable with sharing one thing that you will do in the next week to learn, change, act, explore, or question systemic racism and its impacts on the pandemic oncology social work and/or your community. If you would be so kind as to share something in the chat box, what I'd like to do, and I'm hoping this is okay with everyone, is I want to turn those responses into a collective blog that I will write for Oncolink that stands as a statement of what we as oncology social workers are going to be doing to help with questioning systemic racism that is happening in healthcare. And Hannah and Jordan have assured me that they are going to be able to download the chat box and send it to me. If you can't think of something right now, that's totally fine. I encourage you to send me an email, and I have my email address on the next slide. You can also find me on Swan. I'm on the Hoover app. Send me a little notice. I also wanted to share some really important anti-racist educational resources, both in a social work space and not in social work spaces. But I particularly like the list from Inside LA, which has some really, really great stuff, from talking to your kids about race issues, to books to read, movies to watch, podcasts to listen to. It's really, really an excellent resource. So please stay in touch. Thank you again, Bill, for this incredible opportunity to give this talk, to be uncomfortable, to have support from my colleagues, and hopefully I'll turn this blog into something really special and meaningful for us that we can really have as a going back to piece as a profession of what we're going to do. And I saw in the chat box some of you were interested in book group. I hate calling it club, so that's why I keep calling it book group. But I would really love to have us put something into play to have that kind of discussion. It would be really amazing. So that is the end of my talk, and I'm ready for Q&A.
Wonderful. Well, we are almost out of time. We can take a few questions. If you have questions, send them into the Q&A. Otherwise, thank you for continuing to send those thoughts about participating and helping us become more anti-racist in the chat. Keep doing that as you come up with those ideas. I will be saving that. At this time, we don't have any questions in the Q&A for you, Christina.
Thanks, guys.
If you guys do have questions, I know the Whova app, you can also ask questions later. Christina, if you are willing to participate that way and connect with people through there. We're really grateful to you for this wonderful presentation today, and to all of our attendees for being with us. We're just about at time, and as I'm not seeing any questions coming in, I'm going to go ahead and close us out and just say thank you again, Christina, and thank you to all of our listeners for being with us today. We appreciate having you here, and we look forward to seeing you in our later sessions.
Thanks everyone. Thank you so much for being here.